Right. As I said before, this is about talking about rare mental health disorders. And today I'd like to talk about somatization disorder. And it's according to the International Classification of Diseases, version 10, it's a disorder in which there is a presentation to the doctor with multiple unexplained symptoms, which can affect different organ systems like the gut, the bladder, the kidney, the arms, the legs, and other parts. Usually it starts early in the before the 40s. It can be very chronic in children. Sometimes it's not that long, and it lasts only a shorter period of time. As I might have been saying in different talks before, at the moment we're transferring from ICD-10 to ICD-11, from DSM-IV to DSM-V. So there's different names for different diseases. So the same diseases have different names by different classification systems. So you might have heard the name undifferentiated somatization disorder, or hypochondriasis, or somatic symptom disorder, or bodily distress disorder. That's the newest one in the ICD-10. So they all almost mean the same. The clinical things have usually patients have a long history of different problems in different parts of their body. Usually their symptoms are quite non-specific, and there are very little objective findings. Many patients have lots of files and lots of examinations, and sometimes there is a bit of a discrepancy between the pain, which is explained to the doctor, and then some whatever activities and which people can do. So let's be honest, people might have problems with their arms, their legs, and then might be able to run or play tennis at some point in time. And then at some point in time, they might be struggling to move their arms. Right, okay, so usually lots of files have been examined, lots of examinations have been done, and most GPs then have an awful lot of interaction. And their patients have tried lots of therapies, including possibly antidepressants or alternative therapies. Usually the diagnosis of a somatization disorder comes when there are no positives. It's difficult because it's not positive to have cancer, but if negative means that there's no confirmation of any disease. So then symptoms might change, and there are lots of different examinations. Sometimes people have these warming or tense and creams and all this lots, which might or might not help. Frustration is high because neither the patient gets the help nor the doctor can help, and sometimes can be very frustrating for different members of the team who have different approaches. So many patients have comorbidity. That means they have other mental health problems, usually anxiety, depression, some paranoia, some have personality disorders, and substance abuse can be a problem to deal with the symptoms, or maybe the cause of the symptom. Usually there is no clear etiology. Somatization disorders are very often found in family members, and sometimes have some association with childhood sexual abuse. The prevalence in lifetime is that lifetime prevalence means patients or people have it in their life is less than 2%. So 2 in 1,000 might have it once in their lifetime. In some areas it's different. It's a bit of tradition that symptoms are very often seen as part of something threatening. 5 times more females than males are involved. And as I said, the age of onset is about childhood, late childhood, to 30s or 40s. There's other differential diagnosis, which have to look at. It can be quite challenging. Multiple sclerosis, AIDS, paraneoplastic symptoms. So all these things should be excluded, and this can be quite challenging, especially if some of the investigation just doesn't need blood samples, but might need a lumbar puncture or anything like that. Right. So usually the diagnosis is made by the examination of the psychological and problems as well as the physical problems. And about there's lots of psychiatric comorbidity, especially pain is a problem. So sometimes, there is a firm belief that something might have caused something. So if that's a clear connection, let's say a dysfunction of the gut is caused by a specific interaction or specific argument with the partner, then someone can involve in the term hypochondriasis. So pain is a very common symptom, but people might have also some function loss, which might be seen as a conversion disorder. Some people, if they're not believed, they might try to produce these disorders by cutting or harming themselves, and trying to do this to be understood. That's when you call it factitious disorder, or you just malingering if there is a benefit and so some intentional production of symptoms. Sometimes, this is, might lead to a very negative interaction between patients and doctors. What's very important is to focus on the negative physical finding, possibly the psychological understanding of the problems. So in this respect, it's very essential to communicate properly, to acknowledge the symptoms, and trying to make sure that the patient has the emotional support and can build bridges and can accept any improvements. Usually one shouldn't take too many drugs at all, but sometimes, what happens very often, the patients already, due to the comorbidity, get antidepressants or antipsychotics or anxiety medication. Usually it doesn't have to have too many doctors involved. And usually then there should be regular reviews, not just when people deteriorate. So there should be some clarity about what to do with deteriorating symptoms. It doesn't make sense to go to the A&E, and many of the people who have somatization disorders are not really very welcome in the A&E department. It might be helpful to understand the meaning of the symptoms and the relationship with the physical and mental health of the patient, and then trying to develop a clear plan how things can move forward slowly. So it doesn't mean to run a marathon, but maybe if patients have problems with walking, that starting small walks, small steps, and then see how they can work on this. Sometimes, working in the psychotherapy is helpful. CBT or group psychotherapy might be helpful, but sometimes, it's going to be quite frustrating for the patient and for the doctor if the symptoms don't change or even change to something different. So full recovery is possible, but it might be a program to understand the suffering of the patient and to give meaning to the symptoms, but also to the improvement for the patient. Okay, thank you.